Well, it's the time for the last session of the morning and the meeting. Unfortunately, it's too late. I am surprised because it's not useful in the international meeting, the late plus 1 hour. But maybe it's the relaxed time. For the next session, we need is very strictly with the presentation time. I'm sorry, because it's 20 minutes for each presentation. There are 5 presentations. We maybe spend about 140 minutes. It's too late this morning, and we need to adjust the time. Thank you. I am sorry. And in the first presentation, it was the work of the paper of the professor Han Henkens from Stuttgart, and he will talk about the recanalization of extra and intracranial vessel after subacute and chronic occlusions. Thank you, Professor Henkens.
Good morning, ladies and gentlemen. Thank you for the introduction. I will try to be as brief as possible. We analyzed our workload from the last 8 years and found in several thousand interventions we had done 35 patients with 36 events that had treatment for chronic or subacute occlusions. The target vessels you see here below listed 5 ICAs, 5 MCAs, 13 vertebral arteries and 7 basilar arteries. The 2 middle cerebral arteries with chronic occlusion we recanalized. I won't show you because both got re-occluded, so I think it's probably not a good idea to do this. The others are of interest. The vessel reconstruction was achieved as attempted in 32 out of 36 cases, so there were 4 failures. Clinical improvement was clearly observed and achieved in 30 out of 36. Permanent deficit, nevertheless, was present in 16 out of 36 patients, though these patients are really sick. 4 patients died. One of those patients, the death was related to the endovascular procedure. And as you will see, these procedures are not kind of a standard treatment. They are highly individual, very demanding procedures. And I try to show you common elements to these procedures and to the technique of treating these patients. Very important is a proper workup for elective cases. So if a patient comes and is in an unstable situation, it's a really good idea not to quickly go to the angio, but to do other work. We should consider alternatives like bypass surgery. It's very important for these difficult cases to manage the expectations of the family. We should early on tell the family that this is nothing that comes with a guarantee of success. All these treatments, you will understand in a second, certainly need general anesthesia and dual platelet function inhibition. We found flat panel CT quite helpful because you're really working in the dark. You're recanalizing a vessel that is no longer visible, no longer there. The most products we are using for these treatments are off-label used products, coronary products. MRI is important afterwards. And DSA follow-up is very important because many of these patients have a tendency for recurrent stenosis and may need eventually retreatment. The first case is a man with a recurrent left hemispheric TIAs. The left ICA was occluded. He had poor collaterals, as you may see. The reserve capacity was measured both on perfusion CT and ultrasound and was exhausted. We used proximal balloon protection, dilated the ICA, stented the ICA, had to go for mechanical thrombectomy of both ICA and MCA, and finally achieved a good clinical outcome. This is the MR image before. He had this little lesion here, nothing serious otherwise. Poor collaterals from the posterior circulation to the left ICA. ICA itself on the left side is occluded. These are the dural collaterals, and this is the ACOM collateral from the right side. So altogether, there is flow. I mean, the patient is not comatose. He has TIAs. There is flow, but I think from the whole situation, you can tell, as it was found on CT perfusion and ultrasound, that there's poor flow in the left hemisphere. This is a very typical list of products used for this procedure. It's hardly possible to do this with a single balloon and a single stent. This is a really mass business until you get the vessel recanalized. You need a balloon guide catheter, aspiration catheters, a series of microcatheters to get the way through. You need several wires, you need stents to recanalize, to reconstruct the vessel. You need balloons to angioplasty, and in that case, eventually we need thrombectomy devices to remove thrombi from the vasculature. Very important for the ICA, I think, is to have bilateral access, so you can have an image from the healthy side and get contrast from the other side to the side you are working on. Here you see the balloon in the proximal segment of the left ICA. The wire is already through. We usually leave the wire in place until the very end of the procedure, so you guarantee that you have access. And if you don't use a balloon catheter, you may even go for an 8 or 10 French access catheter, so you can have the wire and other instruments beside the wire to guarantee access. So we catheterize through the occluded ICA, end up in the MCA, gently inject to make sure that this is not the wrong lumen. And in this very moment, the microcatheter is certainly in the MCA. Now we dilate from distal to proximal, stepwise, the occluded vessel under proximal flow control. Insert the wall stents. As you see here, the vessel is already straightened, the proximal lumen is reopened. This is injection from the right ICA to make sure that nothing serious has happened above. Vessel still occluded from proximal, the wire is still in the left MCA. Now, antegrade injection from the left AC. There is thrombus left in the cavernous segment, as you see here. Now we go ahead and remove the thrombus. This is thrombus and stenosis, which has to be taken care for. Still in the MCA, dilatation of the cavernous segment, and now the MCA is occluded. Part of the thrombus had gone from the ICA to the MCA. Now we have to go back and do thrombectomy from the MCA, which is now reopened. And the vessel is nicely reconstructed. Thrombus is gone, no damage in the anterior circulation of the left side. This is February this year. Before February, nice reconstruction. The 3 days later, MR shows no additional severe DWI lesions. The patient is in perfect condition. This is follow-up in June this year, shows the persistent reconstruction of the artery, no damage, perfect anatomic and clinical outcome, no more TIAs. No damage from the mechanical thrombectomy. And the next case, recurrent TIAs and cognitive impairment related to bilateral ICA occlusions, poor collaterals on both sides. As expected, the reserve capacity is exhausted. We staged the reconstruction of the ICA, started on the left and continued on the right. We had a periprocedural C fistula on the left side, and the lady had an MCI nurse, which was occluded. Again, a very long list of devices. We use catheters and balloons. These are certainly not cheap and certainly not quick procedures, as you may imagine from this. And maybe it's worth to mention that we seal the CC fistula with these flow diverters. Other products, for these cases, we quite like these chronic total occlusion balloons from Invatec. These are very low profile balloon made for coronary total occlusions, works very, very well for cranial vessels. Another good tool is a coronary wire run through from Terumo. It's again both cross-it and run through nice wires, again for coronary purposes made and used off-label in these circumstances. This is a right frontal ischemia, and the lady has no more flow from their ICAs on both sides. As you see here, there's flow from the posterior circulation and collaterals, but no direct flow from the ICAs. The collaterals on the angiograms, the right ICA occluded, the left ICA occluded with some residual lumen. This was the reason why we started here. This is poor transdural collaterals. The vessel is catheterized, the left ICA is catheterized. We again go, as you had seen before, for balloon dilatation first. And you see here this, the tight stenosis, which was dilated, and this dilatation, the vessel is sealed with wall stents. This dilatation certainly caused the CC fistula. CC fistula is now sealed with a stent graft. The stent graft didn't seal entirely the fistula, it just reduced the shunt volume. So we put floater vertis inside, dilated the floater vertis, and ended up with this result, pretty much shut of the fistula for the left side. No damage on the left side at this moment, fortunately. She still, of course, has the ischemia on the in the right frontal lobe. Follow-up a few days later, and coming back to the right side, she had thrombus in the right proximal ICA, which was removed with thrombectomy, and dilatation as before from distal to proximal, as you see here. Stents in the ICA. This was in February 2012. Perfect reconstruction of the artery. This is February 2012. We were reluctant to treat the MC aneurysm instantaneously. She was also reluctant, and she came back, I think it was this year. Yeah, this is follow-up on the other side with the instant stenosis, which was dilated with a drug-eluting balloon. She came back this year for the MC aneurysm, which was easily coiled. We did a little more coiling than this is pictured here. Another case, dizziness and drop attacks. Both vertebral arteries occluded. The right vertebral artery occluded in the V4 segment and the left in the proximal V2 segment. Some collaterals from the right to the left, but certainly not enough flow in the posterior circulation. We constructed the left vertebral artery with coronary stents and floater vertis. In general, I could say I like much better the results with floater vertis than with coronary stents. Both was, in that case, as you will see, anatomically and clinically very good. No perfusion, no diffusion lesions, just hemodynamic compromise, which is a very good condition to deal with. So this MR shows this occlusion of the right V4 segment and occlusion of the left V2 segment with some collaterals from the right to the left, little downstream from the anterior circulation. This is the proximally occluded left vertebral artery, easily catheterized from the arm. One way is through, in the far majority of cases with these chronic occlusions, you really dissect the artery. So you should be prepared that you not only go for angioplasty, you should really go for fixing the dissection. You caused by yourself a minute before. This is the dilatation of the fresh dissected vertebral artery. Treatment was done in November 2014 with pretty good result. These are the floater vertis in the vertebral artery in November. This is the final result in November, and this is no damage, and this is the follow-up in January this year. Perfect reconstruction of the vessel, no damage clinically, and good reconstruction. This was is an older case. The man was known to be both alcohol addicted, and he was known to have a chronic basilar artery occlusion. He was on an outpatient basis in a psychiatric program, and he obviously misunderstood the command he should not drink. So he stopped completely drinking, not only stopped drinking alcohol, and became comatose within 2 days. And what I'm going to show you is kind of complex reconstruction of the basilar artery. And he's a real long-term survivor. The primary treatment happened in 2007, and he's still alive. He lives in a psychiatric institution and is now able to walk and to drink. This is the initial MR showing no more posterior circulation, no more basilar artery, no more vertebral arteries. And this is the left vertebral artery, which is obviously occluded after the pica origin, and there's literally no downstream from the anterior circulation. This is the left. This is the right ICA, the left ICA. Nothing's really reaching the mid-basilar segment, the proximal basilar segment. The right vertebral artery as well as occluded. And we tried both sides, and it looked a little better or more promising on the left side. I think there would have been arguments to try either side, left or right. So we actually went up on the left vertebral artery, catheterized it, and immediately dissected it. This is the effect of the run-through catheter wire. These wires are really brutal things. They are not made for soft medicine. These are brutal wires. dissection of the basilar artery. And as you may imagine, it's really difficult to get an access to the right lumen. As in all dissections, the right lumen the true lumen is collapsing, and what you see here is the expanded lumen is certainly the false lumen. We solved this by coming from the anterior circulation, going to the PCOM P1, going down from the anterior circulation, which is done here. Catheter is inserted through the posterior communicating artery downward, and as soon as you have the wire in the true lumen, I will show you in a second. As soon as you have the wire in the true lumen, it's way easier to catheterize it from below. You come from above, you go down, and you expand the collapsed through lumen with a wire and with a microcatheter, and then you will certainly find access to from the false lumen to the true lumen, which is done here. This is the important step. You have to go down, and from anterior you go up from posterior, and you catheterize the true lumen. Angioplasty, the dissection of the basilar artery, and fix the dissection with stents. These, I think, were neuroform stents. Relatively good anatomic result in December 2007 with his pontine infarcts. I mean, he was highly hemiparetic, but no more comatose. This is in May the next year. It's 5 months later. The basilar artery is again occluded, but now the way is paved. There are stents inside, so it's no big. The other is still occluded, of course. So it's no big deal to similar situation. No collaterals. So it's now way easier to go through this stented vessel, go for thrombectomy, and re-stent the vessel. May 2008, angioplasty, more stents, full mantle jacket now. And this is still May, vessel fully patent. This is summer of the same year. He develops now a proximal vertebral artery stenosis on the left side, which was in October of that year was stented. This is a coronary stent for this newly developed vertebral artery stenosis. This is January 2009, following year. And this is follow-up in in April 2014. Still alive, modified ranking 3, living independently in psychiatric institutions. So what can be said about these procedures? They are, I mean, apparently, given the circumstances, these are high-risk procedures, technically demanding high-risk procedures. The best indication to do these things is hemodynamic compromise. I would be slightly reluctant to do this in patients who are not suffering from hemodynamic issues but from recurrent emboli. The work prior to the procedure is important. We always consider alternatives. If our neurosurgical friends say we would prefer to go for a bypass, we never stand in the way. We always prefer bypass instead of doing these things. Dual platelet function inhibition from the very beginning is crucial. You have to be prepared to use stents. At least in Germany, you have to tell the patient and the family that this is not doable on the basis of an unlabeled use of products. It has to be off-label. You need afterwards aggressive blood pressure management. These patients have to be kept on blood pressure, arterial blood pressures below 120 millimeters mercury for a couple of days. Otherwise, you have a high risk of reperfusion hemorrhage. You need MR after the procedure, you need follow-up, and every now and then you will need retreatment. Thank you very much.
Thank you very much.
Right?
Sorry?
Did you observe?
Yes, okay, it's good. I thank you for your strict. You saved 3 minutes. We had the time for some questions. The discussion is open, please. Any question? Comment?
Good.
You have the difficulty to put the stain, wall stain in the petrous portion of the carotid, or you put the neuroform stain?
No, we only use wall stents in the cervical portion. We don't go so high. We use, at this time in 2007, we had no flow diverters, so we use coronary stents. Today we use flow diverters. For everything beyond petrous and beyond, we go for flow diverters. Rich country.
So my question was, maybe I misunderstood the whole thing, but Are these chronically occluded arteries, or are we talking about acute thrombectomy?
Wait a second. There's some percussion in the background. Yeah.
So are these chronically occluded arteries that you're trying to open, or
Are these?
are chronic occluded arteries?
Definitely chronic occlusions. Yeah.
So once the person has tolerated the occlusion, why were you trying to open them?
Because they are hemodynamically compromised. If a patient is no longer, if a patient has TIAs, and if a patient starts to complain of being unable to think and to keep things in his memory, I think this is the most frequent reason for this is hemodynamic compromise. The only reason for this kind of adventure is to fix hemodynamic compromise.
I mean,
Okay. Any more? Any more question? The last question, please. Wait, the microphone. That's it.
Such cases, if there is a hemodynamic compromise, the technical challenges and the risk of procedure is so high, particularly in the vascular system. Did you consider alternative option of extracranial to intracranial anastomosis in these cases?
I mean,
That would be relatively...
if you go by numbers, I mean, certainly not for the basilar artery. If the patient is comatose from chronic occlusion of the story is completely different. If you have a chronic occlusion of the basilar artery and the patient deteriorates, which is frequently the case, there is no other alternative. The patient is going to die, or you open the vessel. This is different for the anterior circulation. If the patient has a hemodynamic compromise in the anterior circulation, a bypass is certainly a good choice, and we actually do way more bypass surgery than doing these things. The reason is if there is, let's say, any argument against any kind of bypass surgery. I would rather argue for bypass surgery for the anterior circulation than for going for this kind of massive.
Thank you very much. Yes, the last question. Thank you very much, Professor Hankins, and you will continue for we need very strict the time. The next presentation was about the acute stroke management. The next speaker is the Professor Mayos Muniz. He's from Boston Medical Center University. Thank you very much.
Well, first of all, I'd like to thank Professor Lopez for asking me to come here, and moderators. I'll try to keep in time, but I was promised 30 minutes actually. But anyway, we'll see. First of all, I wanted to talk about some concepts before trying to understand how and why we do things the way we do. So, the first question we want to ask myself at least is, are all strokes, ischemic strokes, or gyrations fit the same mode? So then can we homogenize them and do a clinical trial, which then answers the question of how to proceed forward? The answer is no. Patients are individuals. They have different problems, and you cannot homogenize the population to have a clinical trial, which really would make perfect sense. Then do we need rigid time windows? Do all brains behave the same way? Do we have a 3-hour window or a 4-hour window or a 6-hour window? And again, the answer is no, which is apparent from multiple trials that have shown very different kind of outcomes depending on how they've been done and what the outcome results were expected. So the third thing was, then can we improve on the current way we manage acute ischemic strokes? And finally, should TIAs be treated in a different way than acute ischemic strokes? So going by that, so, I mean, no trial is complete without this pivotal trial, the NINS trial, that actually showed us that IV-TPA can be used effectively. And it did show that there was a absolute risk reduction of 30%, and with the expense of 6.4% higher risk of intracranial symptomatic hemorrhage. Having said that, if you however, if you break down the NINS trial into patients that had severe strokes based on NI stroke scales of greater than 20 and NI stroke scales of less than 20, you see very different results. You see that the outcomes are really poor in patients with severe strokes, and outcomes are fairly good in patients with mild strokes. And this can be further broken down if you break it down by complete NI stroke scale scores. For example, you have 0 to 5 NIH, where there's absolutely no difference between TPA and placebo. Between 6 and 10, there's a whopping difference of 16.6, not 13.3, but 16.6. So these mild strokes really do very well with IV TPA. And then you have, as you go up on the severity, the numbers keep dropping to 10.4, and then above 20, the numbers are actually 3.8, which means you shouldn't be giving IV TPA to patients. You're doing more harm than good. So again, if you look at the risk of bleeding, the symptomatic bleeding risk is much lower with mild strokes, and the symptomatic risk of bleeding is 17%, not 6%, with patients with severe strokes. Another blush trial was the ECAS-2, the European Cooperative Trial, which asked for a perfect outcome of modified Rankin score of 1, 0 to 1, which means a person should have only symptoms or be completely free of disability with a drug. That is not perfect. That is not going to give you the perfect answer. So the same trial, and the window was 0 to 6 hours. The same trial was redone, reanalyzed, with using a modified Rankin score of 0 to 2, and it was found to be a positive trial, showing that patients are able, if 0 to 2 is very acceptable outcome, which is now commonly used in the recent trials. So, having said that, that means that the patients, the time window can extend to 2 hours, or 6 hours actually, from not just stop at 3 hours. And based on these 3 trials, then we drew this hourglass, which basically shows that beyond 4.5 hours, there is no particular advantage. But then you are using the end results of these 3 trials, which is Atlantis and the NINS, as well as the ECAS-2, and with imperfect endpoints. So there's definitely noise that is in the system, that there is room to go beyond 4.5 hours. But having said that, the ECAS-3 trial was done, which proved the point that yes, you can. If you exclude severe strokes, if you exclude all major strokes, if you have only minor strokes with a median NIH of 8, you can certainly achieve some sort of an outcome, which is half of what you would expect at 3 hours. So certainly time is important. There's no question about it. But besides time, collaterals are important. There are different, all patients, some patients may have chronic ischemia, which allows collaterals to develop in time, and they sustain epineura much longer. So you cannot sort of mesh all of this together and create this individual trial. So based on that, if you look at the rate of recanalization, the rate of recanalization for internal carotid arteries and basilar arteries with IV TPA is only 8 to 10% at best, and that is optimistic. For MCA M1, 25%, and as you go down distally to smaller vessels, the rate of recanalization increases to 56 to 60%, which fits in with the data that we just discussed. the NI stroke scale. And these are the arteries, obviously, that don't do well with IV TPA. You have an occlusion of the ICA, basilar artery or middle cerebral artery, M1. IV TPA is pretty useless. Having gone through all this, we developed our own model, which is basically saying that you should have a quick assessment. You should keep the NI stroke scale score, of course, but use imaging, vascular imaging, as a predominant determinant of how you would treat patients. So you have non-contrast CT scan, CT angiogram to determine the vessel occlusion, and perfusion CT, which is performed on every patient. That's the standard thing. And if we need to then go forward, we then go forward to an angiogram. So this is a non-contrast CT, of course, which is normal. That's the CT angiogram showing you a MC occlusion, M1. And then you have your CT perfusion, which is the idiot box, which anybody can read. This shows a great perfusion deficit. And this patient, however long, I don't care if it is 6 hours or 8 hours, should be treated. Because there is a holding pattern in which there is no infarction, there is a large vessel occlusion, and there's a huge penumbra that you see here. And then the angiogram, of course. So our annual stroke burden is about 800 patients a year. 18% get IV thrombolysis, either directly in the hospital or through telestroke. And about 5% of these 18% get, about 5% of these get IA interventions. This was our old model where we had, we just gave IV TPA because that was the thing to do. And if you see that the effect of IV TPA on, if you break them down by large vessels and small vessels, you can see that with small vessel strokes or distal strokes, you have 58% good outcomes. And with large vessels, the outcomes keep dropping. Similarly, if you look at the modified Rankin scale of 0 to 1, divided by large and small vessels. So small vessels did great with 0 to 1. Large vessels, 0. If you then go forward to Rankin score of 2 to 3, 4 to 5, and 5 to 6, you keep seeing the large vessel occlusions get bad results because the simple fact is that they do not recanalize with IV TPA. And moving on to, so then following our protocol, our protocol is to start IV TPA and then if the patient does not improve, move to angio and not wait for the 3-month outcome, which has been pretty dismal as far as our own experience is concerned. So this was our intra-arterial interventions, and you can see that the interventions were done for ICA or T occlusions, M1 occlusions, and some for posterior circulation. We did not have too many posterior circulation strokes, thankfully. And as you can see, the discharge status is completely different. Patients, 28% patients were discharged home, 40% went to acute rehab, and there was 20% mortality. Now I'll explain the mortality in a second. It is basically that patients who did not wake up on day 1 or day 2 were made comfort measures only, meaning the relatives told them that we don't want these people to have aggressive treatment. So what chance would they have of survival at any point? So I'm not sure how to judge this 20% mortality. It wasn't because of failed therapy necessarily. It was you withdrew care, so patient will die. Just wanted to run a few cases if you have time. So this was a 29-year-old woman who had a rheumatic heart disease and had a really large stroke with aphasia, right hemiparesis, and neglect. Got a full dose IV TPA, and this was her occlusion. You can see that there's an M1 occlusion on the left, and this was her perfusion deficit. She had a small area of ischemia here and a huge MCA that was left to be saved. Missing some pictures here, but anyway, the point was that we waited on this patient for 4.5 hours, and finally got the catheter in the groin at 4.2 hours. And Dr. Baklu did a great job. Thanks to him, he recanalized the whole thing at 6.5 hours. And this patient was discharged from the ICU directly home in 3 days. So, making the point that not everybody dies or is not retrievable after 3 hours or 4.5 hours. Here's another patient, 40 years old, NI stroke scale of 20, anticoagulated with a therapeutic INR. Also, on angiogram, had a dissection. Again, Dr. Baklu was the man, and he stented this and opened up the dissection, and results were phenomenal. There was a T occlusion on top, which also was thrombolized. So, and all of that took a lot of time. It took more than 7 hours to finish. Here's our patient with the CT scan 3 days later, and you can see that there's not a huge infarct anywhere. What about wake-up strokes? I mean, that's another story that we've been following. We treat them exactly in the same protocol with exactly the same way. We do the CT, CTA, CTP, and if they have this is some data from Dr. Hitchinski's initial study, where they showed that wake-up strokes treated with IVTPA have the same results almost as the NINS trial patients achieved. So based on that, and based on our own protocol, I just want to show you a case where a patient went to bed at 10:30 and was fell out of bed at 4:30 in the morning, and was seen in the emergency room at 8 o'clock. So you can imagine this is completely out. And I was 23. And this was the deficit, with minor infarctions, but large area of penumbra. You can see the results of the wake-up was that on day 3, the NINS dropped from 20s to 10, and on day 8, the patient was discharged to acute rehabilitation. My last 3 slides, just want to show you that we treat TIAs exactly in the same way. If they are large vessel strokes, they get urgent CEAs. If they have atrial fibrillation, they get anticoagulated in the ICU. And we manage the other risk factors as they should be managed. And so this patient came in, angiogram was performed. He had a left vertebral thrombus, but symptomatically had an NI stroke scale of 0. So we kept him in the ICU, and sure enough, 7 hours later, he had a recurrence of symptoms. And when he got recurrence of symptoms, he was taken to the angio lab, and through the contralateral word, a catheter was put in, and that word was shut down. And the patient became completely symptom-free and was discharged. So the point I'm trying to make here is that the clock starts when the next fluctuation begins in TIAs. TIAs, I mean, if somebody has a TIA and recovers, the clock doesn't start from the time that he had the first TIA. You start the clock from the second time, as the point. And just a couple of, I'm sure somebody will talk about this, but the 3 failed trials, the 3 intraarterial failed trials, we thought we had to give up intraarterial therapy completely, but all 3 had some limitations. Long times to intervention, primitive devices were used like Mercy, and very poor patient selection and poor training. So that led to these three other trials, the SWIFT prime, the positive, and MR clean. And two of them are positive. I mean, MR clean, of course, is a very positive trial. Somebody will talk about it right now. SWIFT prime is going to be discussed in the International Stroke Conference. It is going to be positive. And so that brings us back into the picture again for intra-arterial therapies. Thank God. So in conclusion, all I want to say is that IV therapy should be chosen selectively for patients with low NIH stroke scale scores. You should not deny IV therapy because it's FDA-approved therapy which has to be given, but know that you will probably fail and take the patient quickly to intervention and try to open up these arteries with intra-arterial interventions, whether it is additional IA or devices. Because now you have Trevo and Solitaire and things that really do well. Finally, I want to say that please do not go by rigid time windows, but go by a patient. Look at the CAT scan. The CAT scan looks completely normal at 6 hours. No infarction at all. And if the patient has a large occlusion and has a huge penumbra, treat the patient. Thank you.
Thank you very much. It's very interesting. Maybe with the next presentation of the Mr. Clean is complete the idea. But I want only one comment, because in the first 6 hours, do you think it's really necessary to make the mixed match? Because in Mr. Clean, the thrombectomy was made without mixed match in the first 6 hours.
Right. So Mr. Clean, again, we can talk about the results of Mr. Clean, but it was image-based. The whole point of it was that you standardize it with best medical treatment, which includes IV treatment or best treatment.
Okay, thank you very much. The next presentation is follow this field. Is the explanation about the analysis Mr. Clean trial. It was presented by Demetrius Lopez from University Medical Center from Chicago.
Thank you for having me here. I'm going to get this presentation. Luis asked me to put this together when we got here to Madrid. I think that it's a very important topic, and I'll share with you what I saw in Istanbul during the World Stroke Conference. And so the Mr. Clean is definitely what we were talking about, the evolution on the field in terms of how we get to obtain answers of what's the best way to manage patients with stroke. It went through a process that started with the first trials, and you saw a large review of how we got to the medical the indication for the intravenous TPA, and then subsequently the trial called IMS3 was a very important trial because it demonstrated to us many things, that point out to us many things that we had to do better to add another tool, another weapon on the armamentarium to fight stroke. And that was all the side of arterial surgery or intra-arterial therapies needed to be better tailored and better understood how they could have an impact. So the beginning of this started by identifying in the IMS3 which population didn't do so well and which patient group could perhaps benefit the most from intra-arterial therapy. And one of the lessons was that we had to move into a image-based indication. So having a CTA demonstrating that there was actually an occluded vessel, and hopefully you can prove that this vessel occlusion has a large clot, 8 millimeters or more, or T occlusions. These things points out a patient group that will not respond very well to TPA. So this is an ideal group to investigate another form of therapy, because IV therapy was not good enough for these patients. So when this trial was put together, it's basically a multi-center randomized clinical trial that was using stroke centers in the Netherlands. And they were extremely clever on putting this together with the support of their government. And but the main things is that this trial design was being duplicated in many other parts of the world. So the nice thing about this is that Mr. Clean is the first trial out of potentially 4 or 5 trials that will be having the results in the next few weeks. And they all had a similar design in a sense that they were prospective trials. This one had 500 patients, and you're looking at all patients had a confirmation of an intracranial vessel occlusion on CTA. And the term LVO, as you see here, is large vessel occlusion, and that's going to be a very important part of this. And the idea here is that you had to use, in one arm was a medical arm, is receiving IV TPA, and the other side was receiving a catheter-based therapy on top of the standard TPA. So what we saw here, the assessment, and this is just how the trial was designed, basically the MRS score also being important. It's not about only revascularization, but it's about the functional outcome afterwards. And the initial impression was that there was no safety concerns. This is what we saw in Istanbul, and then we were waiting for the New England Journal of Medicine publication. So this is, I'm going to go over that data in more detail now, but I think that we all learn, and this is just a very large, let's say, spreadsheet explaining all the trials that we have going on compared to IMS3, and pointing out some, not only the lack of image-based definition of which patients were going to qualify, also was important that the technique of endovascular surgery had to be improved. So with new tools such as the stent retrievers, it made a tremendous difference on the percentage of patients that got recanalized. In IMS3, you had a very low rate of recanalization compared to the standards of today. So it's very important that you start putting this together. The first one, diagnosis of large vessel occlusion. So you have to have a method to screen patients to make sure the brain is alive and large vessels occluded. Then the next thing, you have to have a center that can quickly activate an endovascular team that has the latest technology on revascularization of the vessels. So it's not about any just opening of the vessel. You have to open with a complete opening, TT3 or TT2B. So this is important because when you look at IMS3, and there was already a hint that patients that had better revascularization, TT2B to TT3, they had the best outcomes. So this is known even on the IMS3 trial. So the issue here was how can we then, can we prove that this, if you select only the patients that have, the syndrome that we described, the large vessel occlusion, high NIH, if they would then fare better in a trial that prove that they had still viability of the brain as well as large vessel occlusion compared to a BTPA alone. And I think that what you're going to see here, there was another lesson is related to what was disclosed in the previous lecture. The location of the occlusion is quite important. And if you have lesions on the T occlusions are famous for just being very high resistance to TPA, IV TPA alone. So that having a trial that has a large presence of patients with T occlusions would be of benefit also. So all the stars had to align to make sure that we were testing the right population for intra-arterial therapy. So this is kind of the bottom line, the takeaways that we learned from the IMS3, and I talked about this, so I'll be glad to discuss, but these are very important points that what's different between now and then. And I will share this with you because in the United States, what made a difference for us is that we are we divided in primary stroke centers and comprehensive stroke centers, and that's a very important definition of what these trials mean to us, because before then, being a primary stroke center or comprehensive stroke center, it only made a difference on the hemorrhagic disease, but ischemic disease, there was very little difference. But today, it makes a huge difference once this trial is, and the other trials all become available. The importance of having centers that can deliver IA therapy and the screening of the right patients to go to those centers is going to be crucial for us to make a difference on this disease. Now, let's talk about Mr. Kling then, and this is now reviewing the New England Journal of Communication, and I think that this is a large paragraph, but worth to go through these bullet points. The issue here is that we have a 71% improvement in good neurological outcomes for patients treated with intervention compared to medical managed TPA. So that was only 32%. So it's a very important issue that there was now an improvement in neurological outcome if you have the IA therapy. There was no safety difference, which is a very important aspect, because the concerns with intracranial hemorrhage as well as the 90-day mortality, they had no difference between the two groups. The other important issue is that the patients had a presence of a better ranking score at 90 days if they were part of the interventional group. And that is something that we always had a hard time to prove that would have a role, but in this particular population studied, it seems to make a tremendous difference, and it's statistically significant. The main thing about the trial too is that we don't have yet specifically the breakdown of all the devices that were used, but the majority, 97% of the devices were stent retrievers. So this is a change from IMS-3 that had a much less penetration of devices like stent retrievers. So this is the timeline. The study was from 2010 to 2014. The window was 6 hours for treatment, and this is some of the criteria for inclusion on the trial. But you see here, very important, 500 patients, large vessel occlusion, and you can see the secondary primary endpoints. Now, let's just go a little bit on the data. I think this will be of interest for most of you. The demographics, the groups are very similar in their characteristics and presentation, and age, quite similar in degree of severity, as well as left hemisphere involvement. So the groups paired very well, and I think that this, when it comes down to the pre-stroke ranking score, also there was an amazing parity, and so the randomization process is very good. The other thing that is very important is that the level of occlusion of the lesions was able to be randomized very well. So you have a very good mix of T occlusions in both groups, as well as M1s and so forth. So I think all that made the trial extremely strong. The issues then regarding the endpoints, and the MRS score 0 to 1 in 90 days, you see that 11.6% of the patients were the intervention group, and only 6% on the control group, and this is statistically significant. So there's an improvement on outcome at 90 days on the interventional group over the control group. This is another important aspect, which is the difference between the clot, the region that was blocked. So the T occlusions are here, M1 segments, of course, is a lot of the cases, but the very proportional distribution of the clot of the patients in both groups. The use of stent retrievers is one of the things I point out. It was the majority of the cases were with stent retrievers, and probably has a huge reason why the trial has the results that it has. Now, the issue of revascularization, the quality of revascularization, and it's something very important for the interventional, and if you're a neurologist, you should really be aware that there is intervention and there is real intervention. And the point is that if you don't get a TK3 or a TK2B, and I'll be glad to review that definition with you if it needs clarity, but the point is that no distal embolization. You have to have a complete opening of the blood clot, otherwise your results are not going to be the same. And I think that this just goes to show the importance of the post-operative period. You have TK3, 24%, 35% at 2B. These are numbers that are extremely important in account for the results. Now, the proof of that is that they had to prove the recanalization at 24 hours with CTA, and the interventional group had a much higher level of revascularization. But I'd like to point out one thing here. It's just many times we see a patient that receives TPA, and in 24-hour scan, you may see the clot is going away. And it looks that they revascularized, but the problem is the time that it takes for that to happen. So if you take IV TPA versus IA therapy, I pose to you that a challenge here is now how fast can you take the clot down? And I think that this is important because even though you revascularize in 24 hours, the brain did not tolerate the time that it took for the clots to be eaten by the thrombolytic in a sense. So large clots, they seem to fare better with intervention. Now, the issue with the NIA stroke score, I think that this is also pretty good, showing that the impact is more at 7 days when you have a larger distance between the control group and the interventional group, that they had lower NIA stroke score, which was a favorable score in the 7 days, but this was already shown in 24 hours after the intervention. In also another outcome scale revealing that the interventional group had a better score than the control group. Similar to MRS. And these are numbers, I don't want to be too repetitive and take too much time, but this is available in the New England publication, but not only on the MRS, but the NIA scores and recanalization was improved on the interventional group over the control group. Now, this is the ranking shift analysis showing that the majority of patients, if you look at the interventional group, they are living on in the areas of the lowest ranking scores, and I think that this is very important to notice that we could not show a significant improvement on the ranking scores on previous trials, and I think that this is really highlighting how all those improvements allowed us to then see the benefit of this therapy. This is just a very good slide to demonstrate all the different safety endpoints, and I think here it was extremely equal on both sides, so showing that there was tremendous safety on this trial. Of course, this trial was done in the Netherlands by a group of physicians that we need to see if worldwide it will be the same, but we have trials on the way that will show that perhaps. So here there's no statistical difference in safety endpoint between medical and the interventional group, control and interventional group. Now, interesting enough, in a subgroup analysis, older patients in ICA occlusions, they tend to be better on intervention. And so it's an interesting aspect of this subgroup analysis on ICA occlusions in older patients. Points then is the use of the stent retriever technology allowed us to have better revascularization than we did before. That is the importance of the difference of IMS3 to Mr. Clean trial. Another aspect is there's a high number of ICA occlusions on this trial, which is the most benefit for intervention is in ICA occlusions. Also, the confirmation of vessel occlusion with the imaging, we use MRA, but CTA is reasonable. There are different ways to prove that, but it's reasonable that the one spends the time to do we call advanced imaging, showing brain mismatch, as well as small volume of stroke, as well as large vessel occlusion. The issue of long delay between IV TPA and intervention is something that we're definitely working more and more on this and cutting down the times between them. And I think that issue in this trial may have been of benefit because it showed patients that were not responding to TPA, and I think that those patients then had the most benefit because they likely would not revascularize anyway. And I think that Mr. Klein was a great achievement of the group from the Netherlands, and because it was done in a time that it was challenging to prove the point of this, and it was difficult to pull this, and to do a consecutive enrollment without bias was very important. And I'm going to show you, this is one of my last slides, just showing the difference between when the neurotechnology was used in this population compared to the other trials we had before, and the ability to obtain a high level of revascularization. In this case, it was about 59% of TK2B. I have to say that we can do even better than that, but this was already enough to show the improvement in this therapy. Now, I will quickly mention to you ESCAPE trial is a similar trial done by the Canadian group, and this trial is apparently, from what we hear, it's been stopped right now because of overwhelming efficacy also. And then Revascat is another trial that you're familiar with, based in Barcelona. It seems that the story is very similar. And the Extend IA is an Australian trial. All have a very similar design. They use the flaws from IMS3, where we learned the lessons learned from IMS3 and adapt to these trials. Swift Prime is the other trial that I wanted to mention, is a US trial, and Therapy also is another trial in the US. All these trials today are being evaluated for their results to be hopefully presented at ISC in Nashville in a few weeks. Now, where we're going with this, I think I would say this is the take-home message. It's very important that today the neurology group, the neurosurgical group, interventional group all gets together and understand that patients will do better if they have a selection by advanced imaging showing that there was an occlusion in large vessel and the brain is still viable, or small volumes of stroke. Use stent retrievers with aspiration or balloon guide catheters. Faster and more complete recanalization, so TK2B and TK3 is very important. And the time management is always important, so community awareness and patients getting to the hospital as fast as possible is very important. Thank you very much.
Okay, thank you very much. Professor Lopez, very interesting presentation, and I think it's a very good news. Mr. Klein published, and also the recent data for the ESCAPE trial. I think it's definitely the confirmation of the efficacy of this treatment, and resolve some doubts related to the hacker expressed in the editorial paper related to we need a new trial. Well, the new trial is ESCAPE, and maybe the SWIFT and another. Thank you very much. I think it's very important the find of the efficacy in the international carotid artery occlusion, because in the first study maybe it's not considered, or some people consider it's not indicated the thrombectomy in internal carotid artery. I think Mr. Klein definitively established the efficacy in this point, and the no exclusion patient by aspect criteria. With aspect criteria decrease, the result is low, but it's better as nothing.
Yeah, I think that the type of imaging you choose will be based on the medical center a little bit, but the minimum will be an aspect score. But if you are able to perform CT perfusion, but certainly a CTA is important, and an aspect score that as a minimum. But I think that as we advance on this, perhaps faster MRIs or the availability of MRI is a possibility to improve that path. The other path is basically even intra-angio suite imaging. So a lot of the flat panel technology is improving to try to make diagnosis in the suite. I have to say a big job is going to be for the paramedics and the population to be able to screen low image to see the likelihood of need high treatment.
Thank you very much. Well, the next presentation is about the development of the new stroke practice. This topic is presented by Professor Ricardo Hanel from Mayo Clinic, Jacksonville. Yes, thank you. And do you speak Spanish also? Un poquito.
I think it's going to be just following what Dimitri was saying. I think our goal, our task now, that finally we've got a trial that is positive to show that intervention works, is to organize ourselves a little bit like our cardiologist colleagues did 20 years ago. We're 20 years behind. And I'm going to show you a little bit what I did. I stay in the same city. I worked for almost 7 years at the Mayo Clinic. And stroke was one of the major reasons that I left, because I couldn't get the support to do what I had in mind to do at a place that was very well established, probably the strongest brand in medicine in the world, that is the Mayo Clinic. But the support for this endeavor was not there with the intensity that I thought was necessary. This is a tremendous teamwork. You cannot do this by yourself. This is not a one-man show where you're going to do, oh, I'm the only interventionalist. You cannot do this alone. It has to be a tremendous teamwork. Our colleague from UMass showed us that already. Why do you need to be involved in this? It happens every day. If you think aneurysm is common, ischemic stroke is 5 times more. The numbers are getting worse in the US. Obesity, diabetes, elder population getting, so stroke is going to happen more and more and more. Again, vast majority of strokes are ischemic. I think I put this slide there just to remember that just like NINS 1995 changed the way we face stroke, now finally on December 17, 2014 is going to be a historic day for us. We have the first study that is going to turn this into a standard of care, and every single hospital is going to try to establish this. Just like in the US, every single major hospital has a coronary unit to intervene upon a heart attack, and that's what we have to work. What we say in English, assistance process. How can we organize all the way from EMS to the interventional point and post-care? How can that be organized? There's no question, and I was very fortunate that I got a very, very business-savvy, community-driven administration from a hospital system that allowed me to do that. And I'll show you here a couple of things that we did. But it's a major joint effort between physicians, allied health staff, and administration. Hirsch Niemi showed us yesterday what grows fastest in a hospital is the administration side. They have to be on your side to make this happen. I brought a guy that worked with me in Buffalo, and he's French-Canadian. I'm Brazilian, we drew a line in the middle. And if you come to the shore, Jacksonville is right there, it's North Florida. Wales don't have aneurysms, they don't have stroke, so we found somewhere in the middle. We put a plan together. We're very lucky that this building was already in place. So this is a 11-story building with 7 floors dedicated to neuro. And you don't need that. I think the walls are nice, but the system is what is important. We had the 2 biplanes in the OR, 12 beds in the ICU, the idea of creating a neuro-emergency department. And I'm just going to spend 1 second talking about this before we go forward. I think we need to organize our emergency rooms in a different way. Just like we have a cardiac surgeon, a neurosurgeon, an interventional neuroradiologist, people very specialized. Our EDs are, with all due respect, a zoo. Every single patient is triaged by the same person. We need to have somebody at the ED that can recognize that problem, and we're focused on that. So we have opening in 2-3 months a space and a pool of physicians. Our group of ER physicians at our hospital have 140 physicians. It's impossible to educate all these guys at the same time. So if you can focus that to 20 guys, you just educate those 20, and they will help educate the others. But those are the focus guys that are going to be seeing these patients at the first pass. No question, this is a huge, huge multitasking. You have to coordinate radiology, neurology, and everybody that is demonstrated here. You have to explain to your people, this is a system process just like a heart attack. When you get people to buy into that, that's a great beginning. Every single hospital in the world has the vision how you should manage a heart attack. This patient should go as soon as possible. For door to balloon times are standard. You know, all these things are standardized for MI intervention. We have to do exactly the same thing for neuro intervention now that we have data to back us up. So if you go to your hospital, you have to start the conversation saying, this is heart attack. Just like we manage a heart attack, you have a PCI tech on call. They have 30 minutes to be on the door, and all those things that you have to coordinate. But if you start the conversation, administration that don't have the knowledge that we have about stroke, they will understand your message that this is heart attack. We're going to manage a stroke just like a heart attack, and people will learn from that. We visit a series of different places in the United States and abroad before, and I would say, and I'll focus here in 3 points for you for sake of time. It's a very, very complicated process, but we have to educate EMS. EMS with a heart attack, we have the advantage on the heart attack side. That is a 12-lead EKG. You can diagnose that at the door of the patient, and before the patient gets to us at the ER, you know there is a heart attack coming, and the red phone is ringing, everybody on the PCI lab is aware, and go from there. We need to educate, and with education, you can get these people pretty good, the paramedics, to identify stroke on the field. And if somebody has a positive Cincinnati or a positive LA scale, and the guys from North Carolina are working, developing a very simple test, put your hands up, how many fingers you see. If that test is positive, you can tell this is with an 80% chance of this being right, that is a stroke. So it's very, very important to get EMS empowered to identify this before the patient comes to. Another thing that is very important in terms of education, we start that, we copied this from Erlanger and Riverside, Ohio guys. Just like Covidian, Codman, Stryker, Penumbra, Microvention have a rep that will come to you. You have a rep that is, we call stroke liaison. This person is giving feedback. So Sergeant John brought this patient with an NIH of 20. Dr. Lopez did the intervention. The patient is better. So this person is going to go to the EMS crew and tell, look, this patient did very well. He's going to go to the ED physician. This patient did very well. This is not only marketing, but more important is education. You're giving feedback. These guys will never forget. I grab the EMS truck when I go to the ER to grab the patient and say, come see the intervention. Again, with solitaire, trivo, and aspiration. You have stroke intervention that lasts 10 minutes, 15 minutes. You tell this guy, come walk with me to the OR. They will never forget that you did that, and they will never forget next time they see a stroke patient on the road. The emergency room is probably the hardest point to organize because of the chaos of every single emergency room that is busy. I think you have to have education to the physicians to organize your stroke center, but you have to educate everybody, from the front door man to the nurses involved, CT tech, MR tech that can delay your MRI in the need, and so forth and so on. Remember that time, when we say the time is relative, and I'm guilty too, that we spend a lot of time saying, oh, we can extend the window, time is not that important. No, time is very important. You have to save time. It doesn't mean that you cannot do anything beyond 4.5 hours. Dimitris just presented to us Mr. Clean at 6 hours. Escape is going to be 12 hours. And there are things being done up to 36 hours in the near future. So I think that's very important to remember. And that's one thing that you use for education. Every 15 minutes, you lose 4% chance of a good result with TPA. So every hour is 16% down. Something that I think will make a revolution, will be a revolution, and will widespread very quickly now that we have proved that intervention, we have something else to offer, and time becomes less of an issue with the 4.5 hour going to 12 hour, especially for large strokes, is take that EKG to the patient. We cannot do that naturally. We cannot push IV-TPA in somebody that has a bleeding on the brain. Our major enemies, it's impossible to say at the first visit assessment, is this ischemic or is this hemorrhagic? And sometimes people have a hard time understanding that EKG, again, there's not such a thing as a hemorrhagic myocardial injury. So they push IV-TPA based on an EKG lead. We are going to start bringing our big EKG machine, also known as a CAT scan, to the patients. The first in the US was the guys in Houston, but the one that is working more actively are the guys at Cleveland Clinic, and we are in the process of getting this machine. I think Berlin was the first city, completely city-wide. I recommend that visit. I think it's very nice to visit Berlin and see what they're doing. Alberta in Canada did something a little bit different, using this machine for underserved areas. So what you have is a truck that goes with a driver, a paramedic, a nurse or nurse practitioner, and a CT tech. You drive that truck to the patient's room. So the way this works, every time somebody in Cleveland dial 911, the City of Cleveland dispatcher said, oh, my father cannot move his right side, so City of Cleveland identify this is a possible stroke. So a fire rescue truck is dispatched to this person's house, and at the same time, that truck with the CAT scan is dispatched. Whoever gets to the house of the patient first, or whatever place the patient is, mall, whatever, that person is going to provide first care. If the fire rescue gets there first, they may combine and say, okay, let's meet at exit 33 of I-95. So the care is provided at the door of the patient. So you cut all the transportation time, all the ER evaluation time, and there's a teleneurology, boom, on the machine. So there's a teleneurology consultation being made. The neurologist, radiologist, neurosurgeon is seeing that CAT scan when the CAT scan is done. 2 minutes later, you have on your iPhone, whatever you use, you have that machine right there, and you're assessing that. You just cut 90 minutes, 2 hours of wasted time. And the IV-TPA penetration, and that's our dream for the next 12 months, and I think that will change care of a stroke, not only ischemic, but improve on hemorrhagic side too. In Berlin, and the first 6 months of operation of this in Cleveland, the penetration of IV-TPA that is not as good as UMass. UMass, 18% of IV-TPA is a very high number. On average, in the US, that number is about 6 or 7%. So in Cleveland, that went from 6 or 7%, no, Cleveland Clinic was 12%, was good, and went to close to 50% IV-TPA penetration. But there are centers, before we started at this health system, the IV penetration of our site was 4%. So you see that that is a fantastic way to push IV-TPA. And very, very, very interesting, the reason that Cleveland Clinic started this operation was we are coming to a point that the government is going to come in the United States here. This is a bag of money. Take care of this patient for 90 days. So whatever happened to that patient during 9 days is your responsibility as a system to take care of that patient. So they start saying, how can we cut stroke care cost? Rehab is very expensive. In a very, very interesting business model analysis, the only way or the best way to cut rehab cost is saving patients up front. So if you can get these patients better, more patients better, you don't have patients that are spending time in rehab facilities or nursing homes. And there is a huge halo effect of the ambulance walking around, talking about this type of situation. You have to organize systems. We used to work before in a system that, okay, you have a transfer coming. The only thing that you have is a phone conversation. This is 1990s. Today, there's no reason that you cannot have. You can do this with iPhone for free. They can put the camera, you FaceTime with the physician, they put the iPhone in front of their computer, and you look at the CAT scan, is there blood there or not? Oh, we don't have anybody to push IVTPA. Go teach these guys to push IVTPA. Naturally, you can do this in a less regulated way, or you can do that in a very regulated way. And unfortunately, we live in a country that is very regulated, so we have to do this in an organized, documented, HIPAA-compliant way with privacy for the patient, so forth and so on. So we start with our 5 hospitals, soon to be 7 hospitals. We ally ourselves other 3 hospitals. So now we're in a system that have 10 hospitals that will be connected. And starting the 30th of this month, we have PACS capability, so I can log into a computer and look at the CAT scan, CTA, CTP that is being done in other hospitals. Starting this month, when this CAT scan is done, I don't have to log in a PACS. I can be watching a soccer game, and this map here, that is a very nice calculation of everything that is going on with that CTA, CTP, with multiple different phases of the CTA being analyzed on top of the CTP. This comes to my iPhone, and I'll be able to say, within 5 minutes of acquisition of the images, I'll be able to see this. So I have a conversation with the physician. Patient is here, or our nurse practitioner is there, or neurologist that is there. This patient has an age of 18, and I'm looking at this. You're just saving there 15, 20, 30 minutes from processing of a CTA, CTP. I'm going to skip through that. It's pretty standard. We do use IVTPA, and I think we should push hard for IVTPA to prove otherwise. I think it's important to be consistent. The people on the system need to know that this every single time is the same thing. Push, 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 time, time, time. They'll call you boludo, they'll call you all kinds of different things, but that's okay. You're there to push. And you have to remind people that that's not for you, that's for the patient. I agree completely with the UMass team that time is irrelevant on the sense that imaging will guide intervention, but now we have evidence, level 1 evidence, showing that up to 6 hours intervention does benefit people. And hopefully in 2 weeks, we're going to have evidence that up to 12 hours will benefit people. Now we're starting going away from now, this is A, B, or C expert opinion. This is level 1 evidence, and that's what the neurology community needs to make this happen. If you think the neurology community is hard, start dealing with the ED physicians. There was a cover of one of their most important journals 2 years ago saying that IVTPA should not be used. That's the level of respect that we get from the colleagues that are not experts in what we do. They don't believe TPA work. They don't want to push IVTPA. There are many neurologists that I know that they are very, very skeptical and reluctant to push IVTPA. Dimitri showed that. I think the discussion is more important than this. We know we can open vessels. We can use all kinds of tools. This guy had a dissection in a curve. I used Solitaire, ended up stenting his dissection with pipeline. We use different systems with aspiration, and we have all that available. Having all that available means nothing if the patient doesn't get to you. So you can have the best cath lab, all these tools on your shelf. If you don't have patients, that's a very, very mute and expensive point to make. You have to get the patients to the cath lab. It's going to get better. I think there are a couple of things, and this is just a little tool that is coming. Dimitri showed that. Distal embolic was very well demonstrated on Mr. Clean, 5.6% of different territory embolization. This is the Lazarus that you have a stent retriever, and that can work with their stent retriever or with any stent retriever, that you push this layer here, and you see the stent retriever with the clot there, and you create an intussusception on that braid. So when you put the stent retriever, you just push this sleeve, as you see here, 1, 2, and 3. So now when you're pulling the clot has an envelope and does not allow, as you see here, the stent retriever on the inside and this envelope on the outside, very, very fine braid, almost like a super soft flow diverter that is embracing your clot, does not allow for that to break away. I think it's a very, very, very exciting time, almost as exciting as Real Madrid and Atletico Madrid, to be involved definitely more exciting than Brazil and Germany. It's a very, very exciting time to be involved with stroke. I think we're going to make a huge impact for the future of our people, helping people with stroke. Muy contento, Luis, de estar acá con usted. Una festa muy linda. Gracias.
Okay, thank you very much, Professor Hanel. Your first name is Spanish, Ricardo. Okay. Well, I agree because it's very, very important. The stroke care organization, I think, is the basis of the success in this treatment. We are having in Madrid a very good experience with semi-stroke primary stroke center and comprehensive stroke center with the stroke network, and we have agreed with you, and we have the same vision of the problem and the planify the treatment. Maybe we have possibility after we discuss about of the CT, mobile CT, because it's not definitively established care. Okay, thank you very much.
I think the mobile CT makes sense in some areas. In some other areas it doesn't make sense. If you're 10 minutes from the hospital, why are you going to do that? But we have, for example, patients coming from 2-3 hours away, that these patients are about 60 minutes from an ER. So if you could save that time, and more important, I think this is going to help us funnel the patient to the right place.
Maybe, but the Berlin experience is not a good benefit for the patient in the outcome. It's reduce the time, but not the outcome.
So it was just published last week, I think it was on JAMA or Lancet. The Berlin group just published that. The outcomes is definitely improved from, again, if you go from 18% penetration to 50% penetration, if you naturally look just at the patients that got it, I think it may be different, but if you look at the whole cohort of patients that got exposed to the disease, it was different.
Yes, reduce the time, okay, but not the outcome is not significantly. Okay, thank you.
One moment. Fernando Vignola now is in Brazil. I started a new program of stroke. Brazil is a country, very difficult country, because it's very bigger, but have a new idea, new program. It's not expensive, so expensive, similar in Europe or the United States, but the most important is this, is to learn the people. It's important to work with the acute stroke.
Gracias, Luis.
Gracias. Okay, the next presentation and the last for this morning and this meeting is the last presentation. Yeah, the last presentation, but not the less important, because this is the topic is not related to the acute treatment. Is very interesting the role of the statin, and the topic is entitled "High doses statin should be used in the most acute ischemic stroke." The presentation is the Professor Muniz. Is the second presentation in this session, and I think it's a very interesting topic, and I hope your ideas.
Just wanted to add a couple of points to our previous speaker, that when they get to the guidelines, national program of the national organization, what has happened is that the care flow plans have become better, and because of designation of primary care centers all over the country, we just got the news hot off the plate that we are now the 5th leading cause of mortality. Not the 4th, not the 3rd, but the 5th leading cause of mortality. So there's certainly a logic to a care flow plan, which every hospital should have and should translate across the country. All right, let's move to something that is I think it's a very important topic. First of all, statins have typically gone through a very bad historical period initially because of the fear of cancers, bleeding, etc., and so on and so forth. So statins were not utilized effectively. And gradually, with the first few studies, the questions that were asked was, can statins reduce the risk of recurrent strokes? Can they improve outcomes of acute ischemic strokes? And then, can they reduce mortality? And how, if so, what is the mechanism by which they would do that? So the first important study that came out was, there were lots of primary prevention studies that had already shown that if patients were on statins, there was a 24 to 36% reduction in the first ischemic event. But for recurrent strokes, the most important study that came out was the heart protection study published in Lancet that showed that using high-dose simvastatin, 40 milligrams, reduced the all-cause mortality by about 24%. The only problem was that patients with prior strokes did not seem to benefit in that group. So patients who had prior strokes but were on simvastatin had continued to have the same incidence of recurrent strokes as compared to placebo. That led to the second study, which was the Sparkle trial, which included those patients, that subgroup of patients, and that convincingly demonstrated that 80 milligrams of atorvastatin reduced the risk of recurrent ischemic stroke by 16%, TIAs by 27%, MIs by 33%, and also showed a trend towards an improved outcome. People were skeptical about cardioembolic strokes, that statins should not be given cardioembolic strokes, and now there are two controlled trials that have shown that they're equally beneficial for patients who have cardioembolic strokes. So there's no excuse now for excluding these patients and not giving them statins. This was an important study that showed that high-dose statins of over 60 milligrams per day had a better outcome than patients who received low-dose statins. So in acute stroke, if you think about statins, it should be high-dose statins, not low-dose statins. Secondly, one should not wait for cholesterol to come back as positive or negative, which has no relevance in treatment of acute ischemic stroke to improve outcomes. It has relevance for recurrent strokes, to prevention of recurrent strokes, but it has no relevance at all for treating acute ischemic strokes. So ours was the first study, and that's why I'm sort of bringing it up. We analyzed data on the utilizing the University Health Consortium, where we looked at a large national database in the US and looked at outcomes of patients who were on statins or not on statins, and defined them as the discharge data is defined as good outcomes was designed as patients who were discharged home, and patients with unfavorable outcomes were the ones that went to nursing homes or died. And this was the demographics, which were fairly standard. Most of our strokes had mild severity, but there were equal number of patients perhaps with moderate and severe strokes. I'll skip to the multivariate analysis directly. In the multivariate analysis, it was very clear that patients who received statins either before the onset of the stroke or initiated statins right after stroke onset had a much better outcome. I mean, the odd ratios were 1.6 and 2.6 respectively, which meant that if you were on statins and you had a stroke, you were 1.6 times more likely to have a better outcome. And what was more interesting to me was that patients who were statin naive and who were given statins right after stroke onset had a 2.6 times more likelihood of a better onset. And the rest of the predictors of poor outcome were stroke severity and post-stroke complications, which are well known as predicting poor outcome. So we looked at another data set to define the 90-day outcome of this, because we only had a discharge outcome. And again, to our surprise, the most powerful predictor in this was that patients who were statin naive and who received high-dose statins at the stroke onset seemed to do very well. They had 1.7 times higher chances of having a good outcome, that is being discharged home or to acute rehab. And this was consistent across the NIH, when we looked at NIH, when we looked at the Barthel index for functionality, and so this was a fairly consistent phenomenon that we saw. This is an analysis that was done, meta-analysis was done from MGH, looking at all comers who've done outcome studies, not recurrent stroke studies, but stroke outcome studies, and have shown clearly that there is a great advantage of initiating high-dose statins right after stroke onset. Again, the North Dublin study revealed the same evidence that in about 448 patients, that statins before or early after stroke onset resulted in a survival advantage, highly significant post-stroke statin use and survival advantage, and better outcome with lower NI stroke scale score. Part of this is to do with reducing infarct size, which is again to do with some of the pleiotropic effects of statins that improve collateral circulation and allow more collaterals to develop very quickly. Should we, if you are on statins, and very commonly when patients come into, they're made NPO, and so they are not able to take any medications for a couple of days. So this prospective study was interesting because they compared patients who were able to take statins all along versus patients that they were not able to take statins for 2 or 3 days. And they showed that the patients that withdrew from statins for 2 or 3 days had a worse outcome as compared to patients that were on statins continuously. So withdrawing statins is really a bad idea, which has again been shown in this very nice study from Claiborne's group in California, where they've shown that if you withdraw, first of all, if you use statins, you have a good outcome. Statins post-stroke, again, replicated our results, that if you start statins after stroke and you are statin naive, you tend to have a much better outcome. And secondly, they also showed, if you look at graph 4 here, that withdrawal of statins in hospital lead to a higher mortality, significantly higher mortality. So, and what is more interesting here is that the effect of statins is more robust on day 1 and 2, so up to 48 hours, the effect remains very, very robust. So we start statins immediately, put a nasogastric tube down if somebody cannot take anything orally, and give them high-dose statins from the beginning, and not wait for LDLs and all that stuff to come back, because it has absolutely no impact on improving initial outcome. But if you wait too long, if you wait 3 or 5 days, then you may not achieve the same pleiotropic effects that you would otherwise. Statins are very safe for long-term use, which has been shown by many, many studies, including the heart protection study, which is now in its 12th year and has shown absolutely no increase in intracranial hemorrhage, symptomatic hemorrhage, GI hemorrhages, or in cancers, which were the 4 most feared things. And very few patients have any muscle toxicity or hepatotoxicity that is again being shown. The risk of actually having myalgias is about 3.4%, and the risk of having rhabdomyolysis, which is the most feared thing about statins, is in the order of 0.000001%. So I've never seen that happen in my life. So the mechanism, as I said, for recurrent ischemic strokes is to reduce LDL, and obviously it takes away from the cholesterol plaques and prevents progression of arterial stenosis. And the goal there is, of course, recommended goals are to reduce the LDL to less than 70. Also, it's equally important to look at sensitive CRP, which was being shown in a primary prevention trial in Jupiter. The trial is called Jupiter, which basically showed that patients who were on rosuvastatin 20 milligrams a day were much less likely to have any ischemic events. These are patients that had normal lipid profiles. So only the CRP was elevated. And so bringing down the CRP by itself, it was not just a marker. Bringing down the CRP was an anti-inflammatory effect. These are the pleiotropic effects. As you can see, there are numerous effects on collagens, anti-thrombotic effects. But the most important thing that it happens is that when you give high-dose statins, you increase endothelial nitric oxide synthase. And that really causes vasodilation of arteries, makes laminar blood flow. There's an anti-thrombotic effect because of this. And there's an anti-inflammatory effect. Macrophages are decreased, inflammation is decreased. There's an endothelin effect, which is again very important. And decreased platelet activation and anticoagulation. That's why it's so important to give high-dose statins, right? And because all of these drug effects are dose-dependent. So it is recommended now in the Get With the guidelines and with any national recommendation that you should initiate therapy with high-dose, maximum dose statins. And what is considered high-dose statins? Atorvastatin 80 milligrams, simvastatin 40 to 80 milligrams, or rosuvastatin 20 to 40 milligrams. Those are the three high-dose, the three drugs that are considered high-dose statins. So, almost at the end. This is where I want to end by saying that statins do reduce risk of recurrent or incident ischemic strokes. They reduce risk of MI, they reduce mortality, improve outcome of patients with or without ischemic heart disease, and there's an excellent safety profile. So you should not worry about myalgias and muscle weakness and so on and so forth. I'll stop here. Any questions?
Thank you, Professor Morris. Thank you very much because it's very short presentation, very summary presentation. And I would like to comment. About of the statin. One moment, please. One moment, Professor Morris. 1 moment. 1 minute. Because we have in our department in the stroke center at La Paz University Hospital, we have the long experience with this idea of the statin. Before the SPARC study, we have some paper related to the benefit of the statin in the stroke outcome. Participate in meta-analysis and so. And recently, maybe six months or the last year, we have published in neurology our colleague Patricia Martinez, the very interesting paper related to the doses and efficacy in the stroke outcome. No? The doses matter. The high dose is better than the low doses, but low doses is better than nothing.
Yes.
Okay, it's very important because this is the efficacy in improve the outcome plus the stroke prevention. It's very important.
And I think one of the common mistake that people make is delaying treatment and then waiting for LDLs to come back or the lipid panel to come back, which has, again, it has no bearing on a huge stroke management. So if LDL will be 30, it doesn't matter, you're not going to treat LDL as 30.
What's your protocol saying?
So what we do normally is, if somebody is getting TPA, obviously, we withdraw from that until the for 24 hours. But if they're not getting TPA, then on day one, they would get red or plus hydrostatin, and we can't get in the protein.
Okay, thank you, Professor Moniz. It's very, very interesting meeting. I have the compromise to end exactly at 100 minutes. Thank you very much for the speakers, for the quality of the presentation, and for the audience. The audience really is the heroes, because at this time it's time for dinner and for lunch and rest. And we thank very much, and I like to give my congratulations to the Professor Lopez for this organization, and let's my word for the Professor Lopez. Thank you very much.
I would like to speak in English, but I don't speak English. Me gustaría hablar en portugués, no falo portugués. Excuse me. I am going to speak in Spanish. Todos sabemos que lo único cierto que como seres humanos tenemos es la fecha de nacimiento. Lo demás no conocemos, pero en ese lapso, mientras atravesamos este camino, se nos presentan ocasiones para demostrar si valemos o no valemos, si somos optimistas o pesimistas, si servimos o no a la humanidad. Quienes sí lo hacen son triunfadores, quienes no lo hacen son perdedores. Y yo quiero rendir un homenaje a un triunfador, a Luis López Ibor. Decirle triunfador porque así ha sido siempre. El hombre que ha gozado a plenitud, que ha triunfado, que se ha esforzado, que ha trabajado en todos los sitios y que como amigo ha servido para dar la mano a sus amigos. Hablo por Latinoamérica, hablo por México, por Venezuela, por Colombia, por Perú y por mi Ecuador. Y cuando así lo hago es porque todos hemos manejado un catéter de la mano de Luis. Todos aprendimos a poner los COIs impulsados por Luis. Él parió en Latinoamérica la neuroradiología. Y si algo somos en esa especialidad, se lo debemos a él. Sería ingrato no decir que le queremos, que le agradecemos y que vamos a hacer el próximo año un evento que va a llevar el nombre de Luis López Ibor. La base de eso ponemos los latinoamericanos y desde luego invitamos para que todos los colegas que quieran sumarse a este homenaje, a este esfuerzo, lo hagan. Luis se merece y como triunfador que fue, es triunfador que va a seguir siendo triunfador y él va a estar en esas jornadas enseñándonos como siempre lo ha hecho. Gracias Luis por lo que tú has sido.
Well, thank you very much. I speak Portuñol, no don't speak Catalan. Okay. And the next year is the Neuro MC is new device, work in progress, limits and benefits. It's the same story. It's work in progress devices, limits and benefits. It's the same date, it's in January. Thank you very much, Professor. Thank you very much, assistants. And thank you very much, my family.